This is the Global Podcast Network, where executives and professionals connect, share, and inspire. Stay tuned for the conversations that drive success.
And welcome back, everyone. I'm going to talk about something today that's often overlooked when it comes to speech and other challenges that involve the motor skills of speech, and that is swallowing. Yeah, we take it for granted. We just do it automatically. So much more going on there, and she's going to give us that deeper insight. As somebody that works with people in many different forms, she offers so much insight at Cape Ann Speech Therapy. Cathy Salciccia joins us on the program once again. How are you doing today?
I'm fine, thank you. How are you?
Good. We have a commonality. We have a blizzard, snowstorms passing through our area. It just keeps
That's
it
right.
interesting, I guess, right?
That's right.
So, speech therapy, when somebody has some challenges with speech, does it sometimes or often go back to challenges with swallowing?
It can. It can be associated with swallowing, or you may have the swallowing problem without an actual speech problem. Um, so sometimes they can go along with each other, sometimes it may not. It's known as dysphagia or dysphagia. It's a disorder of swallowing or swallowing difficulty. It can occur across the lifespan. Premature infants can experience swallowing issues. Pediatrics can have swallowing issues. Individuals with cerebral palsy can have swallowing issues. As you go across the developmental lifespan, there may be many issues that may occur that can result in a swallowing disorder. If someone has a head injury, a traumatic brain injury, they can have a swallowing disorder. So those can take place with children, and it can take place with adolescents, and it can take place with adults. Also, strokes. Anybody who has a stroke may be at risk for having a swallowing disorder. And then, and also the adult neurological degenerative disorders such as Parkinson's disease, Lou Gehrig's disease, which is ALS, multiple sclerosis. Also, people who have dementia may also experience a concurring swallowing problem. Wow. And people with normal aging can actually start to have swallowing problems just because of weakness in the musculature. But it's not just related to that. You can have individuals who have cancer treatment. They may have oral facial cancer, and they may have swallowing disorders related to that, related to the surgery, related to radiology intervention, radiation, where they may lose access to salivary function, saliva function, which can impact their swallowing. People may have tumors. And then you can also have other risk factors such as people have voice problems like myasthenia gravis. I didn't talk about muscular dystrophy. And then also, if someone has, I know it sounds strange, but if someone has a urinary tract infection, and this is particularly an issue for older adults, people reaching their senior years, aging adults, and especially 70s and 80s, they can end up having a swallowing disorder because a urinary tract infection can result in weakness. And the weakness won't just affect arms and legs, it'll affect the swallowing musculature as well.
Everything you've said up to this point, completely understandable. MS and muscular dystrophy and strokes and things like that. Yeah, we would assume that could be part of it, but the urinary tract infection connection, and so prevalent in many older folks.
Right. Which can also impact, in other words, what can happen is it'll start out as a urinary tract infection. They'll get weakness. They won't swallow well. And then they may end up with an aspiration pneumonia because they became weak in their swallowing. They may go to the hospital for the aspiration pneumonia, but they may really have had a urinary tract infection that started the whole
I, no pun intended, I don't have words.
thing. Mhm.
What an eye opener, and one that I will share with a friend of mine who I believe there's a connection there. Um,
Mhm,
wow. A
mhm.
few years ago, I was experiencing what felt like challenges with swallowing. It was on my radar. Like, what's going on there? You know what it turned out to be? And you'll know this, a very
What?
common
What?
reflux,
Yes, yes, and I didn't even get to that part yet
right?
because, I was going to wait to talk just about the different phases of swallowing and how that can be impacted, and how that can impact your swallowing. Yes, and I also had that problem as well.
You think it's a particularly a a big challenge, a red flag, even if it's just a slight change within somebody's swallowing for what it may be temporary, whatever it might be, but it's it represents so much in terms of our physiology, what
Mhm,
swallowing does, the sensation, the feeling that maybe you can't or something has changed. It almost feels like you're being choked a little bit.
mhm.
There's so much going on there. I think that we minimize it. We don't understand how important it is.
No, we don't understand how important it is, and sometimes people overlook it, when it happens. You know, the swallowing mechanism is a neurological mechanism. And it's also, related to it can be related to some orthopedic issues, even
Hmm.
changes in the spine, you know? So, it's one of the reasons why speech pathologists are specialists in this area because we're trained in the neurology and the orthopedic relationship of swallowing disorders, the muscular relationship, the speech muscles, because many of the muscles in the mouth are, associated with it. So it's a huge issue. It speech pathologists' caseloads in hospital settings, it can be one of the top five in the top five of diagnostic areas that they need to contend with. Um, and in hospitals, in subacute rehabilitation, in nursing facilities. So, when there is a potential swallowing problem, the speech pathologist is one of the first people who gets referred to, by the doctor or by the nursing staff.
What comes next? Is it exercises, techniques, guided by the speech pathologist to improve the muscles within someone's throat?
Yes, yes, but yes, that could be the case, but I think before we get to that, what we normally have to do is evaluate it and participate in the diagnosis of the swallowing disorder. And so when a person is referred, we take an extensive history, but we also do what's considered a clinical evaluation. That's one without instrumentation. We will look at the function of the person's lips, their tongue, their mouth opening,
Hmm.
their ability to chew, the ability to cough, clear their throat, and we may listen to their swallowing with a stethoscope. There are certain parameters that we're looking for. The swallow reflex should take place in 1 second. And if it doesn't take place in 1 second and it's delayed, then our ears are up. There's something that may be amiss here. So we're looking at the timing of the swallowing, and we're also looking at how the person functionally eats their food. So we may look at them with different food textures, evaluate that. Also, I neglected to say teeth. We will look at their dentition just to see what their dentition looks like for the purposes of grinding their food. And then we will pay attention to the symptoms that they have been experiencing. And very, very often or the person who referred them will give, if they're not able to, symptoms such as the food is getting caught in my throat, right?
Hmm.
Their eyes may be tearing up. Their nose may be running. Some of that is autonomic reactions, to the problem with their swallowing. Um, they may have food. They may say, "My food is getting stuck." right here in the upper 1/3 of their esophagus, right? There may be multiple symptoms that they're talking about. And so, or in some cases, the food may go down to a certain level and then not go down any further, and it may come back up,
Mm.
right? So, there's only so much that we can see. We can see a lot during our clinical evaluation, but this is when the instrumentation evaluations are really, really necessary. Now, people may be familiar with barium swallows or upper GI series, to look at various and sundry digestive and stomach related issues. But back in the 80s, one of the speech pathologists who was actually one of our professors at Columbia University um, uh, began to create a diagnostic method with radiologists to look at swallowing disorders. And from that came the modified barium swallow protocol. And modified barium swallow is a very non-invasive test that you can send someone for, where they will go in with a speech pathologist. They'll do some preliminaries, looking at their mouth and looking at their tongue movements, but then they will be given some food and some liquid, and it's impregnated with a little bit of barium, not the amount of barium someone has for an upper GI series, but a small amount of barium.
Hmm.
And then they will be asked to swallow. And the radiologist will turn on the equipment and will watch the food as it's being chewed, as it's being transferred over to the base of the tongue, at the point of swallow, as it goes down into the pharynx, and will follow it all the way to the esophagus. And it's done from the front and from the side, and then they will turn the person to the front, and then they will follow that food all the way down the esophagus until it
Wow.
empties out into the stomach. This is a terrific test. It doesn't take a lot out of anybody, and it can give an extraordinary amount of information.
Wow.
And then there's a second test called a fiber optic endoscope. That's one that some speech pathologists do, doctors, ENTs do, where they will pass a tube up the nose and down and look at the vocal cords and ask the person to swallow, and they can get a lot of information that way. But if I'm trying to get some information that is non-invasive, relatively easy for the patient, then I'll refer them for a modified barium swallow. And this can take place in the hospital setting, and there are now more and more mobile units that can come to the patient's home, and if their insurance will cover it, the person, if they're at home and they have difficulty mobilizing, getting to a hospital, they can get right on the mobile unit. There's a speech pathologist, a technician, and usually a doctor on that van, and
Wow.
they can give the information that you need.
That I can't repeat what it was called, but the scope up the nose. I lost my
Well, five,
voice. Yeah,
uh-huh.
I lost my voice 2 years ago. Just a virus, whatever, but pretty substantial, and it was lasting a while. And had that done. Not for everybody. It's
Mhm.
a
Yeah.
little uncomfortable, but reveals a lot. Reveals a lot.
Yeah. Yeah, you might have had that. They have laryngoscopy, which is a little bit of a different test, and so, but the information that you can get is tremendous. The thing about modified barium swallows is it's a test that can give you so much information about what type of diet the person would do best with, where the weaknesses and problems are,
Mm.
any referrals that need to be made to a gastrointestinal specialist. There are some people who may have a stricture in their esophagus, and so the food is just not passing through. A stricture means a narrowing. And so they can go in and dilate the esophagus, make it easier for the person to swallow. And then once you have that, then we can go back to what you were asking about, is what can be done about it. And this is where the speech pathologist will get really actively involved.
Mm.
We will look at the type of diet the person has been eating, what the results of the modified barium swallow tells us, and we will start working with dietary modifications. Sometimes it's behavioral modifications. The person may not be spending enough time chewing. Maybe the person needs more moisture when they're eating. There are some people who eat everything and then they drink at the end. Then
Hmm.
there are other people who have more of a need to eat, chew, swallow, and then once they swallow, to follow it with what we call a liquid wash, some form of, drink that can then wash whatever residuals are in their throat, and that can also be true for the esophagus as well.
I always do. Like that's just the way I eat. Some say, no, you shouldn't be doing that because it messes with the digestive enzymes in your stomach and you shouldn't be drinking. But I find it more comfortable. Then I have a friend doesn't drink anything the entire meal. I'm like, how do you do that? It's so dry. But everybody's different.
Right.
Everybody's different.
Well, everybody's different, but there's also, there are the nutritional aspects of whether or not it does things with with enzymes. But when it comes to the safety of swallowing, you have to do what you have to do. In other words, the intervention may very well be in the taking of that liquid wash every 2 or 3 chews and swallows. And I'm gonna explain why. Um, and I think it's important for the listeners to hear this because this is how they can recognize a problem in family members or in themselves.
Mm.
When you chew, your tongue moves back and forth to move the food from the left to the right beneath the molars. And then once that food is chewed thoroughly, it becomes what we call a ball of food, and it goes to the back of the tongue. And there's sensory organs on that tongue that will trigger the swallow reflex. The reflex. If they don't have good sensation in there for whatever reason, they may not trigger that swallow reflex, right? Or the swallow reflex will be delayed or will be very weak. Once the swallow reflex triggers and it goes over the base of the tongue, there are so many things that are going on at once. It is an elegant neuromuscular system where the base of the tongue will pull back, the back of the pharynx will go forward, and then there are peristaltic wave-like motions that move the food through the pharynx, through the upper esophageal sphincter, down into the esophagus, and then more wave-like movements that will send it down to the stomach. So it's a complicated system. It's an elegant system. And really, anything can go wrong with that system.
Mm. Yeah, anything can go wrong with anything that has so many steps to it. And certainly
Right.
you identify that with swallowing
Mhm,
many more than we ever really considered. What
mhm,
Kathy, what a an eye-opening education today about this. Something that we
mhm,
take for granted and don't realize is what's happening there.
mhm,
And we're just about out of time. We didn't even get into some of the other challenges and how to help people with this.
mhm, mhm. Well, I think if I wanted to encapsulate it, altering food texture, potentially altering liquid textures. The liquids may need to be thicker, maybe not, but
Mm.
maybe they need to be thicker. Um, Exercises that in the swallow, and we have maneuvers that we can teach the person to do in order to strengthen that swallow mechanism. So if I encapsulated it into that, that would help. And then also behavioral interventions, not to be impulsive, chewing the food more, getting that bolus together, and then altering solids and liquids can help a lot.
Wow. Thank you for today. If anybody wants to learn more, talk with you, connect with you, it's capeandspeechtherapy.com, correct?
That's correct.
I'm still processing the urinary tract infection and the connection to swallowing. That is just, but you know what? Not for details because it's irrelevant. It makes sense with a situation somebody close to me had with their parents. Now it's making
Oh,
sense. Yeah.
yes. Uh-huh.
Wow. Thank you for all of this today. I really appreciate it, and looking forward next time we get together.
My pleasure. You take care now.
You too. We'll be right back.
This is the Global Podcast Network, where executives and professionals connect, share, and inspire. Stay tuned for the conversations that drive success.